Welcome. We're about to simulate a consultant-level Viva exam. We'll walk through a classic general surgery case step by step to help you absolutely ace your board exams. Let's begin.
So here's our roadmap. We'll start with the case, move through history and exam, diagnosis, management, hit the acute complications, and then wrap up with how to succeed. Remember, a structured approach is everything in these exams, so pay close attention to how the candidate breaks down the case.
Okay, let's dive right in. Candidate, please prepare yourself.
The scene is set. Candidate, you have a 60-year-old male with epigastric pain. How do you proceed? Thank you. Well, I would start by taking a really thorough history to characterize the pain and, importantly, to identify key risk factors. After that, I'd follow up with a systematic physical examination to look for any corroborating signs. First things first, I'd focus on the major risk factors. H. pylori and chronic NSAID use are the big ones. They can increase the risk of peptic ulcer disease a whopping 5-fold. Smoking is another key player, doubling the risk. I would also make sure to ask about critical illness stressors, because I'd want to be mindful of less common causes, like Cushing ulcers from head trauma and curling ulcers from severe burns, things that can be easily missed.
The timing of the pain, especially in relation to meals, is a classic distinguishing feature that I'd really want to clarify. With a gastric ulcer, the pain typically gets worse with eating because the food stimulates acid that then irritates the ulcer. But with a duodenal ulcer, it's the opposite. The pain classically shows up 2 to 3 hours after a meal and very, very often wakes the patient up from sleep.
My physical exam would be absolutely systematic. After a proper introduction and getting consent, I'd kick off with a general assessment and a full set of vitals to check for any instability. Then, I would zero in on a focused abdominal exam. And finally, a complete exam including the groin, a digital rectal exam, and the lower limb so I don't miss any peripheral signs.
Okay, let's pause here. Notice how the candidate is looking for signs of anemia, chronic disease, and potential malignancy. Things like pallor or koilonychia, those spoon-shaped nails, suggest iron deficiency, maybe from a slow chronic bleed. And a Virchow's node in the neck or an Irish node in the axilla, those are really ominous red flags for a gastric malignancy. This shows a comprehensive and, most importantly, a safe approach.
Excellent. The patient has mild epigastric tenderness on palpation, but is otherwise stable. How are you going to confirm your diagnosis?
Right. At 60 years old with new-onset dyspepsia, this patient's age is an alarm symptom all by itself. This makes an urgent upper GI endoscopy totally non-negotiable. My main goal here isn't just to find an ulcer. It's to aggressively rule out an underlying malignancy, which has to be a top concern in this age group.
Precisely. That is a critical safety step. Now, what if the endoscopy showed an ulcer in a really unusual spot, say the distal duodenum or even the jejunum? If the ulcer were in an atypical site, that would immediately raise my suspicion for something like a gastrin-secreting tumor, Zollinger-Ellison syndrome. I would immediately order a baseline fasting serum gastrin level to look into that possibility. Very good. The endoscopy confirms a 2-centimeter benign-appearing ulcer on the Leicester curvature of the stomach. Biopsies are taken. Outline your management plan. Okay, so we'll start with medical management. The foundation is going to be aggressive acid suppression with a proton pump inhibitor, probably for about 8 to 12 weeks. The biopsy will tell us about H. pylori, and if that comes back positive, I'll start an eradication regimen. Bismuth quadruple therapy is a common choice, but I'd make sure to tailor it to local antibiotic resistance patterns, and then confirm we got it with a urea breath test after treatment. Okay, and what if the ulcer just fails to heal despite all of that? What classification system helps guide you towards the right surgical approach for gastric ulcers? Before you even think about picking an operation, it's essential to classify the ulcer using the Johnson classification. This system is just crucial because it connects the ulcer's location to the patient's acid levels, and that's the fundamental principle that guides your choice of operation. Now take a look at this. Here we see the most common type, type I. Notice its location on the lesser curvature, just like in our patient. This is typically associated with low acid secretion, which means the problem isn't too much acid, it's a breakdown in the mucosal defense. That's a key point. Now let's quickly look at the others. Right, a type 2 ulcer is different. It involves both a gastric and a duodenal ulcer. And unlike type 1, these patients usually have normal to high gastric acid levels, so acid is definitely part of the problem here. Correct. Now for type 3, which is a pre-pyloric ulcer. As you can see, the location is different, but just like type 2, it's also associated with high acid secretion. So the surgical strategy for both of these is going to focus on reducing acid.
and a type 4 ulcer is way up high on the lesser curvature right near the gastroesophageal junction. Like a type 1, this is a low-acid state ulcer, but its location, so close to the esophagus, makes it technically really challenging and a high-risk spot for a resection. So for those ulcers with high acid, like types 2 and 3, a vagotomy is on the table. A highly selective vagotomy is more physiological because it saves the nerve of Laderjet and gastric emptying, but it's a tougher operation. A truncal vagotomy with a drainage procedure like a pyloroplasty is often faster and simpler, which can be critical in an unstable patient, but it does carry risks like dumping syndrome. For a refractory disease, or for a type 1 ulcer like our patients, where acid isn't the main problem, we're talking about resection. The standard is an antrectomy where you remove the ulcer-bearing part of the stomach. Now that has the lowest recurrence rate, but it means you have to reconstruct the GI tract. The two main options you see here are a Billroth 1, which connects the stomach to the duodenum, or a Billroth 2, which connects it to a loop of jejunum.
Excellent. Candidate, let's change the scenario. While your patient is waiting for his elective surgery, he develops sudden, severe hematemesis and becomes hypotensive. What are your immediate concerns?
My primary concern is a major complication. Given the hematemesis and hypotension, acute upper GI bleeding is the most likely culprit, hands down. But I have to keep a high index of suspicion for the other two big ones: perforation, which would present as a rigid peritonitic abdomen, and gastric outlet obstruction.
And here's a classic exam statistic for you. If perforation were the issue, 80% of cases will show free air under the diaphragm on an upright chest X-ray. That's a finding you simply cannot afford to miss. Do not forget it.
I am particularly worried about ulcers in those high-risk spots. A posterior duodenal ulcer can erode right into the gastroduodenal artery, and a lesser curve gastric ulcer, just like our patient has, can get into the left gastric artery. Both of those can lead to a catastrophic, life-threatening hemorrhage. My immediate plan is pure ATLS-based resuscitation. Secure the airway, get 2 large bore IVs in, start blood products, and then arrange for an urgent endoscopy for diagnosis and hopefully therapeutic control. If that fails twice, or if the patient is just too unstable for scope, well, he meets multiple criteria right here for urgent surgery. My plan would be an exploratory laparotomy, control the hemorrhage by oversewing the bleeder, and then a definitive procedure if the patient is stable enough to tolerate it.
Very good. That is a safe and decisive plan. Let's just summarize the crucial points from this whole discussion.
So, what's the bottom line? A structured, safe, and decisive plan is really what's going to set you apart. You've got to master the basics, build your case logically, recognize those red flags, and be ready with a clear, justifiable plan for both elective and emergency situations. That is the hallmark of consultant-level thinking. And that concludes our Viva simulation. As a final thought, consider the question on this slide. It's a classic test of surgical judgment. Use this framework to sharpen your skills, and good luck in your exams. Well done.